Hello, my name is David Winnie and I am an ENT consultant at the Royal Cornwall Hospital. This short video is a PowerPoint presentation of the management of tonsillitis and quinsy in the community. Patients presenting with sore throat will do so due to all sorts of different etiologies. This talk is focused on those with acute severe tonsillitis or peritonsillar cellulitis or peritonsillar abscess, otherwise known as a quinsy. Usually these are pretty straightforward to diagnose from the history and initial presentation without necessarily looking at the throat. Patients will have an acute, relatively short history over a week or so of sore throat, temperature, pain and difficulty in swallowing. There may be a background of recurrent tonsillitis, but equally there may not be. In someone with an acute history like that, we would more often than not consider it to be due to tonsillitis, but it is worth just considering the very rare possibility of epiglottitis and supraglottitis. Patients, particularly adults, can indicate where their sore throat is felt. Getting them to point with a finger may indicate that epiglottitis and supraglottitis is felt in the region of the larynx, as in this lower picture. But with tonsillitis, they'll point to the region of the pharynx, which is the submandibular region just above the hyoid, as indicated in these slides above. Obviously, if it's unilateral, which does occur fairly frequently, they'll indicate one side, whereas if it's bilateral, which is often the case, they'll indicate bilaterally. The other thing we need to think about is how severe is their problem. The patient presents because it is painful and they're finding it difficult to take things by mouth. It is essential to make sure that they have had adequate analgesia. Once they have, if they still cannot manage anything to drink, then that may be an indication for hospital management, but frequently ambulatory care over a few hours can turn the situation around without admission to hospital. The other symptom or sign that's very sensitive for an actual quinsy with pus that might benefit from draining is whether there is trismus present. Trismus is when it is difficult to open the jaw. You don't have to actually examine the mouth, you can just ask your patient to open the mouth, and if they've got some bad trismus, they may only be able to open it a centimetre or so. This will sometimes improve with medical treatment, but sometimes requires drainage of pus from the mouth, even though that can be quite difficult if there's severe trismus. Last in my list here, but most definitely not least, is to consider the patient's airway. In epiglottitis and supraglottitis, there may well be some soft stridor. Sometimes also in tonsillitis or quinsy, but that would be very rare for the airway to be affected and usually means that the diagnosis is not a simple quinsy, but rather a parapharyngeal or retropharyngeal abscess. The exact diagnosis is not important, but noticing the stridor is really important because this should prompt further advice from the ENT team at the hospital. People get quite confused about stridor. I'm just going to take a moment to talk about that. Stridor is quite simply noisy breathing. If the obstruction is at the level of the vocal cords or above, then the noise will be inspiratory. If it is below the cords but in the neck, the noise will be biphasic, and if it is below the clavicles in the chest, then it will be expiratory, and that's obviously a wheeze. Everyone thinks of stridor being a noisy musical inspiratory sound, such as It can be more musical than that, it's just I've got rubbish vocal cords today. Often though, the obstruction is not at the vocal cord level. Stridor will make a completely different, quieter sound and may even just present as prolongation of the respiratory cycle. So this sounds more whispery, such as or even just on inspiration. People use lots of different descriptions of the sound, but the important thing is to recognise that the respiratory cycle is prolonged because of difficulty shifting air in and out of the airway. And if that is the case, it is absolutely worth getting another opinion. So we've established that often a history is enough to diagnose tonsillitis or peritonsillar abscess. Sore throat with temperature, trismus and dysphagia is typical. Examination is obviously helpful, but in an era of COVID crisis, it is quite reasonable not to look in the mouth for your own and the patient's safety. This is the recommendation from our national organisation endorsed by Public Health England currently. If you're going to put a line in, then a full blood count to look for neutrophilia or lymphocytosis, and also a monospot on that same sample is helpful. Glandular fever is an important differential diagnosis. In these pictures at the top you can see fairly classical streptococcal tonsillitis appearance, but glandular fever may present like this. Glandular fever does not always show a membranous exudate on the surface. In the middle picture below that, you can see that this is quite a one-sided swelling with a slightly edematous uvula here, pushed over across the midline, and the asymmetrical swelling here. This one-sided swelling to my eye is a unilateral tonsillitis with perhaps some peritonsillar cellulitis, but it does not look to me like there's any abscess formation there. This is very much the sort of patient who will get better with medical treatment. Below that, we've got again right-sided swelling. This one might have a little bit of pus there, but probably hasn't. This one might well have some pus there. But what I want to emphasise is that initial treatment, whatever the appearance of the pharynx, should be medical. As I said earlier, adequate analgesia is essential, and we will use paracetamol, ibuprofen and Oromorph orally. Rectal diclofenac is also really useful, particularly in an ambulatory care setting, just to get some early pain relief without necessarily having IV access. Dexamethasone is very helpful as an analgesic, antiemetic, and to reduce inflammation and swelling. The oral liquid preparation is fairly easy to take, but alternatively it could be given IV. We would generally give 4 to 8 milligrams in an otherwise well adult. IV fluids are also very helpful in a slightly septic, dehydrated patient, and in a fit and healthy adult we would give 1 litre over 1 to 2 hours. This is a bacterial infection, so antibiotics are appropriate. If antibiotics can be given orally, then augmentin would be the choice, and if the IV route is required, then ceftriaxone and metronidazole. If allergic to those, then clindamycin can be given orally or IV. This is the current recommendation as of April 2020, but the antibiotic guide is easy for everyone to access to check for changes. On the right here, I've included this abstract of a study from the States. This is a study of patients presenting to Kaiser Permanente and gives pretty good evidence that medical treatment, as opposed to draining the abscess, is absolutely appropriate. But if the patient has trismus or stridor, that would be a clear indication for onward discussion with ENT or referral. I think this study gives us some confidence in the medical ambulatory management of these patients, and particularly around the safety profile, for those of us less used to this approach. So this slide shows the local protocol for treating these patients in ambulatory care within Cornwall. There is a similar protocol produced by ENT UK, who endorse such ambulatory management, but have altered their protocol in light of the COVID crisis. They highlight that it is absolutely acceptable to manage these patients without necessarily examining the oropharynx or larynx. If the history suggests severe tonsillitis or quinsy, then that is how we should manage the patient, reducing the risk to our patients and also ourselves. If a significant pharyngeal or laryngeal examination is required, then it's important to consider PPE provision. And if this is in the community and you feel that's required, you should discuss that with ENT at Trelisk. So going through the protocol, the patient presents, you take a history, and if you feel they've got tonsillitis or quinsy, then we're interested in whether they can swallow. If they can, we should treat them and discharge them, and the treatment measures are listed here in the green box, and are essentially what we've talked through. If they cannot swallow, then the most important thing is to give them effective early analgesia. I'd give dexamethasone with this as well, and then perhaps reassess after a short period and see if they can take oral fluids. If they cannot take oral fluids, and if you feel that they would benefit from IV fluids, then a large bolus of IV fluids, as we've discussed, would be appropriate. After an hour, perhaps I would check if the patient can swallow again, and if they can be treated and discharged. If they cannot, then you could commence IV antibiotics and then review again in another hour. Depending on circumstances, it's quite reasonable to review hourly for 6 hours and then discharge when able. Equally, if the patient is not responding to such medical management, you should refer to Trelisk. And certainly if their observations are deteriorating, or if symptoms are deteriorating or poorly controlled, if there's trismus, or if there's coexistent neck swelling, which would make me think about parapharyngeal abscess, or if you're concerned about the diagnosis, and finally, as we discussed earlier, if you feel there's any stridor, then that would require referral to ENT for review. Otherwise, if they respond to your treatment and can be discharged, I don't feel there's any need for routine follow-up. If they have 2 episodes of quinsy, so if this is their second, or if they get recurrent acute tonsillitis according to the guidance available in the RMS criteria locally, then it would be appropriate for them to present to their GP in due course when they've recovered to discuss referral on a routine basis via normal channels to ENT for consideration of tonsillectomy. Equally, if you are worried, then please discuss it with us, and we could of course arrange some follow-up. This slide is just a screen print of the local antimicrobial guide, which I accessed in April 2020. It is of course a live document, so this is the place to look if you think things may have changed. I think that's extremely unlikely in the near future. So finally, regarding our service at Trelisk, there is always someone immediately available to take calls with referral information or give advice. Usually this is the ENT SHO on call who carries a mobile and is accessible via switchboard, purely because the mobile numbers change. There is always an ENT consultant on call as well if that's needed, and with the change in service provision during this COVID period, there may well be times when the consultants are the only doctor available on call, and you'll be able to contact one of us via calling switchboard centrally. At the moment, the hospital is significantly affected by COVID, and so working practices have changed a lot and continue to. So it is worth discussing a case with the on-call person about what's the most appropriate next steps if you need to. Wheel coats no longer exists as an ENT ward, and we've temporarily moved to Kynance ward in the tower. Where patients are admitted to is constantly changing, hence why it is very important to ring us if you have any ENT patient that you want to send to us for an opinion. Thanks very much for listening to this talk. If you have any questions, please feel free to ask, and depending on where you work, it may be best to give your questions to the lead in your area, who is welcome to email them on to me or any of my colleagues to answer.